Hello, everyone, and welcome to the Quorum Podcast. This is where academic medicine meets remote, austere, and resource-limited areas. Welcome back to the program. This is Eirik O'Kelly. This week, we are discussing the Damage Control Resus Ukraine course that we ran earlier this month in Ukraine. Here with me are Dr. John Quinn and Eirik Holmstrom. Lads, welcome back to the program.
Great to be here. Thank you.
Thank you.
Both of you have been on the program before, but for the listeners who may not know who you are, can you tell us a bit about yourself and what's keeping you busy? John?
Yeah, thank you. So I practice emergency medicine in the UK, and I've been fortunate enough to do multiple projects inside Ukraine in the pre-hospital space, really over the past decade or so, a little bit longer if you include some other projects. And that's basically what I've been up to most recently.
Eirik?
Yeah, and I'm attached to the College of Remote and Offline Medicine, as you know, and I'm in charge of the CPD and short courses. I'm a retired flight paramedic from the Norwegian military and running courses for Quorum at the moment.
So the three of us took a deployment to Ukraine. We were invited there by Tactical Medicine North, and we created a course called Damage Control Resus Ukraine. And we did the Train the Trainer course for TACMed North. So tell us a bit about how that was for you. So John, you've been going to Ukraine for a couple of decades. How is this deployment for you?
This was excellent. I really the College of Remote and Offline Medicine really have offered a massive opportunity for Ukraine, as well as for not only the training audience, but really within the pre-hospital environment as a whole. It was great to be able to really invest quite a bit of time beforehand as well for this deployment. So being able to engage with the training audience and the training team, as well as be able to engage with them, several months, I think, going out there to do a site survey about 5 months, 4.5, 5 months before the training took place, be able to engage with the team, see a bit of the training center, get a better feel for the area. Also being able to engage with a really truly professional in-country partner forces team that has just great resources and, under extreme duress and conditions of trying to not only provide frontline care, TACMed North, provide frontline care, they also are doing just cycles of several really high level, very complex training. And so being able to engage with them and be able to support them was really a great opportunity. And being able to see the impact at a very high level, very professional high level was excellent. So overall, I can't help but just sing the praises of our recipient, host nation partners, as well as the rest of the team. Not only everyone on the call, but all the other people supporting us at the college and throughout. Really, being able to provide a significant level of support for a mission such as this.
Yeah, and I can just second that because this was my first trip to Ukraine and I didn't know what to expect. I'm very glad that you had been there a couple of times, John, because that solved a lot of the questions I had going into Ukraine. The other thing that was really, really, for me, a great experience and also awakening was normally we teach courses in Malta and other different places in Europe, and that's for personnel we don't know is going to use what we are teaching them in the near future. But for this course, it was like I had really had to think about my teaching because these guys that we taught down there, they're going straight out to the front line and using what we taught them. And that was quite a awakening and a new experience for me.
So tell us about the DCRU curriculum. What is Damage Control Resus Ukraine?
I think you are best to answer that, John, since you implement most of the curriculum.
Well, yeah, thank you. Well, it was definitely a team effort, and I was really excited to be able to support this. Really, damage control resuscitation, especially in the remote and pre-hospital setting, is access to not only all of the self-aid, buddy aid aspects that we know from tactical combat casualty care, but really it's about having access to blood and having access to blood in the pre-hospital space as close to point of injury as possible. And so, putting this whole course together, we're not going to recreate the wheel. There's several hundreds of people on faculties, all at medical schools throughout North America and Europe, as well as throughout the committees for tactical combat casualty care and the committees for in-route casualty care, etc., as well as other surgical specialties. They've done all the work for us. They've done the clinical practice guidelines. They've been able to support with evidence-based medicine and evidence-based practices the clinical practice guidelines for remote damage control resuscitation, damage control resuscitation in a prolonged field care environment, and damage control resuscitation writ large. So being able to really incorporate those into a curriculum, bite-sized packets, coming off of the deployed medicine website and application, and it's mirrored Ukrainian language content at tccc.org.ua, being able to really synchronize those, put together a package.
So we're talking about the DCRU curriculum, and we chose 3 CPGs to base this off of. John, can you tell us about those 3 CPGs and why did we decide to do it on those?
Absolutely. Yes. So we were able to really highlight not only obviously the prerequisite. I think it's very important that we also really are cognizant of the prerequisites of having, you cannot provide excellent advanced life support until you provide excellent basic life support. And so we kept with that same paradigm when doing the curriculum, saying, hey, you need to have excellent tactical combat casualty care. You need to be really CMC, Combat Medic Corpsman certified, preferably with an appropriate and approved curriculum and training course. And then only then can you really say, okay, listen, we've done this, we're excellent at this, and now we're going to jump into damage control resuscitation. Having said that, the CPGs that we really were looking at and really focusing on, all encompassing, were the prolonged casualty care CPG, the overarching CPG, as well as the prolonged field care and damage control resuscitation, or remote damage control resuscitation CPG. And so there's updated different versions, 2018 with a few updates, 2021 with a few updates, 2022, and then the prolonged casualty care, which is that huge overarching document that really looks into a lot of details that came out in 2024. The most recent update, I believe, April or March. I can't remember entirely. And so we use that as really a template. Now there's references to other CPGs within those CPGs. So if we're talking about burns, then we jump into a burn CPG and we reference that, and it's translated into Ukrainian accordingly. And if we talk about another CPG, we can always jump out from that and say, listen, this is the other resource. But really the major driving force of damage control resuscitation CPGs really falling under that DCR, as well as that DCR, prolonged field care CPG. And again, really focusing on access to blood, access to blood components in therapy, in keeping with the paradigm of being able to provide blood as close to injury as possible. And then being able to walk through those CPGs and say, listen, if you get stuck, that's okay. Go right back to the start and start at the top, just like you do with your patient. And you say, okay, CABC, let me just go right back and follow my Marsh paradigm if I get stuck. And then after that, we can graduate and continue to work on through the treatment paradigm so that we can best serve the patients. But when it comes to the curriculums, that's really what it was set upon, that you already had to have a prerequisite, you had to have that TCCC, you had to have that CMC, and only then, after you do that very well, can you graduate and really push into that damage control resuscitation and provide blood and blood component therapy far forward.
I found the CPGs exceedingly helpful when dealing with the questions from the students, because they would, as you said, they would get through the DCR for PFC CPG, and they get to the point where we're talking about burns, and they start asking questions, and it was easy for us to say, well, you have it downloaded on your, so the DHA has everything converted into Ukrainian, and you can download it and review it for offline. So it was great to be able to talk to them and say, yeah, you tell me, what is the CPG? What are you going to do for the burn? Oh, we're going to treat it as a wound. We're going to cool it. We're going to go through the CPG and do precisely what we're supposed to do. And what we're hoping is they're back at their units and they're continuing to learn off of the DHA app and answering their own questions on a lot of these skills.
Yeah, I think that was some of the biggest takeaway points also for the students, because as you probably remember, the first days they had some problems with or challenges doing this thought process that, hey, I can actually look it up and have a look at it, because they were more used to doing doing without looking up the references or CPGs. But I think at the end, they were really, really good at thinking in those clinical ways that, hey, I'm a little bit stuck. Okay, I open my CPG for burns or for wound care, wound management, and there it's here. I can actually just follow the CPG, and then I will mitigate my problems.
Yeah, absolutely. And I think, I think you both raised great points. These questions were excellent. I mean, these students were absolutely, this training audience were starving to learn, and they really wanted this information. And using the CPGs as this sort of lightning rod and a framework, really a roadmap for the patient care as well as for training, I think was really excellent to have. Uh, the deployed medicine and the mirrored website tCCC.org.ua. I do think it was it's just an excellent resource to be able to follow. And I do just want to give a shout out to the guys at tCCC.org.ua. There's a lot of volunteers there that continuously do a lot of these translations, because the updates, as you know, from the deployed medicine, I mean, it's almost every day. Every day there's an update. They update something about TXA, or they update something about calcium. They have great resources and all of these, these trauma cards and scenarios, as well as videos. And so obviously that mirrored website, a lot of volunteers. So we just want to give a shout out to them, as well as a shout out to the deployed medicine guys who do such a great work and service every day.
We were profoundly lucky because there's a massive data dump on 1 June that they put tons and tons of additional content out on the DHA webpage and on the app. And as we're planning for this coming up into June, and suddenly seeing tons and tons of excellent stuff that helped us out tremendously. So yeah, DHA have done a profound service to Ukraine, and for us who are working in austere and remote environments.
Oh, it's an absolutely excellent. I mean, it's a brilliant resource, and I cannot say more about it. I mean, it's absolutely brilliant, and it's a fantastic resource for for online learning, for patient care, direct patient care, as well as as an outlet to have access to NATO military medicine. There's great resources there, as well as it's a two-way street. Obviously, the committee, all of the committees for different types of casualty care and pre-hospital providers, as well as for other types of medical evacuation, they rely on people having access to that information, and they say, listen, we've done it this way, and we actually found a different an alternative to do it. And they want that information. They need that information to be fed back into their committees, whether it's through a scientific article, peer-reviewed article, published in an impact factor journal, or whether it's an anecdotal experience that says, hey, listen, this is actually quite important. They need that information to be fed back, especially as it relates to the Ukraine experience from large-scale combat operations. A focus on coin operations and counterinsurgency has really generated, the last 20, 25 years of military medicine. And so as we're shifting and we're really preparing for large scale combat operations, it's absolutely fundamental to be based on evidence. And this course was one small little brick in that huge wall of being able to engage with partner forces, learn from partner forces, support partner forces, as well as get information feed and get lessons learned and shared and experience to be fed back into the system to make the whole system better and to hopefully increase the lethality of the warfighter.
It's a challenge to get that data, and there's so much learning that's happening at the moment that we need to capture somehow, and create that into an interoperability option for the large scale combat operations.
Yeah, and I think that one of my takeaway points was that we are teaching people who's actually doing a lot of medicine in the front lines, and it's a little bit different than when I was teaching at SACOM in Germany for the NATO. There's a lot of things we need to rethink, and there's a lot of things that doesn't fit to the way the war is going in Ukraine that we have taught people before. For example, blood transfusion. I totally agree with you, John, that they need more blood. They need blood in. And we, my first thought was to try to see if we can teach them, not teach them, but what their thoughts was about body transfusion. But body transfusion is not not doable because they need so much and they cannot start taking blood, have walking blood banks. They need to be shipped blood daily into the front lines.
Yeah, absolutely. That's a very good point. Large scale combat operations are just such a different kettle of fish, such a different, problem set. And, the walking donor is an excellent process and program specifically for what it's used for and what it's needed for. But then when you think about having, 50 patients, 50 trauma red, category 1 patients, every 60, 90 minutes, obviously blood transfusion is impossible. It's super important to know the process, to understand it, to be able to use it and utilize it. But at the same time, it's just a slightly inadequate resource, for large scale.
Yeah, that was one of the things that I experienced that I really need to rethink, because my point had been that, okay, we need to teach every soldier, like we're doing in Norway with the National Guard. Everybody's learning body transfusion, but when it comes to large scale wars, you need to have a logistic system that can support you with blood.
I was impressed that they had a 5-day blood transfusion course that they were teaching to everyone.
Yes, that's right. I mean, that's a very good, yeah. So the laws have changed in Ukraine, which is great. It's a welcome. Being able to provide blood outside of the hospital in the pre-hospital space is 100% legal and needs to be pursued specifically with universal donor for the very junior medical provider. And for those non-medical providers, the transfusion network inside Ukraine, and the exact, transfusiology network is the translation is a bit tricky, but they established a curriculum. It's 5 days long. It's very long, of course. But after you pass that course and you successfully complete all the tasks within that course, then you are allowed to, as a non-provider and as a provider, you're allowed to provide blood in the pre-hospital space. So we definitely would like to promote that capability for all providers to be able to do it in a legal, in keeping with kind of the governance guidelines within the country of Ukraine. Having said that, it is pretty tricky to do 5 days, and being able to combine that, I think, is something that we're looking to explore and get some sort of alternative and creative options for, so that training audience can not only learn damage control resuscitation, but they can also fulfill the requirements for that course, so that when they leave a course, they can actually say, listen, I understand how the CPGs work, and I've also fulfilled the appropriate criteria in keeping with best practices inside Ukraine for the purposes of clinical governance. And they can provide universal donor blood as close to injury as possible, to really reduce that time from point of injury to getting that patient to appropriate and adequate care.
Yeah, it brings me a little bit back to my first military experience in the early 1980s. In Norway, we actually had, when you were a medic or in the medical corps as a normal soldier, you were actually picked out if you were working in a role 1 or a role 1 enhanced. You were actually taught to be a transfusion assistant. So we were teaching our soldier who had non-medical background, basically, to be supporting and learn how to do blood transfusions. And I think we maybe have to go back to that, because we quit that in the 90s or 2000. So we don't have them anymore. But I think that we need to rethink that and maybe teach more people to do blood transfusion or be transfusion assistants in the military.
Definitely.
Speaking of giving them additional skills, Eirik, you found a couple of REBOA kits that we're able to donate, and John, you ran them through REBOA training at the CMC level. So how are we able to do that? What was the learning outcomes for teaching REBOA at that level?
Yeah, I mean, it was excellent. I do want to say thank you to Eric and for all of the support teams to be able to get some kits in country. So I think it's so important, and Ukraine problem set is really quite challenging and complex across such a massive forward line of troops. So the front line is just huge. And so it's not homogeneous zone. You may have REBOA performed at some stabilization points. You may have REBOA performed at some role 1s or role 2s, and you may have no access to REBOA whatsoever, and everything in between. And it may be it may be contingent upon which doctor, which provider you actually have at a certain location at a certain time, as well as what access you may have throughout that evacuation chain. And they said, listen, we're not going to do a REBOA. We don't have access to surgery, not for 6 hours travel, not for X amount of kilometers, etc. So it's not a homogenous zone throughout Ukraine. So it's really important, I think, just remember that when we think about really advanced interventions, like everything from surgical airways to chest tubes to REBOA, or even blood in the far forward space. But having access to understanding what REBOA is, resuscitative endovascular balloon occlusion of the aorta, I think it's really important um, to really focus on what that actually means, what you're actually doing, and anatomically where you're actually going. And you're going to actually be, you're putting surgically this intervention, and you're actually occluding the largest vessel in your belly. And so that's in some instances it's a partial occlusion. In some instances, depending on the kit that's actually being used, it's complete occlusion. So if you're in the wrong place, you may be occluding additional arteries that may completely make the kidneys fail within moments, really. And if you're in the right place and you completely occlude the aorta, you may actually completely occlude everything downstream, and really have bad outcomes if you don't have access to damage control surgery or damage control surgical interventions to be able to really mitigate that morbidity and mortality. So just to kind of put it within a framework. But then when it comes to providing the actual training and the concepts, really these students were sponges, and they really wanted to understand it. They completely understood that we were not training them how to do a REBOA. This is not a REBOA course, right? You can go and go to spend the big money for the REBOA fancy courses, which have all these great pieces of kit. But it is understanding the concepts, the surgical procedures of the Seldinger technique, the surgical procedures of what you're actually doing, the ultrasound capability to be able to see, hey, where is this in situ? Whether a patient arrives at your stab point, at your goal 1, at your goal 2, and you have a REBOA in situ, or whether or not you may be supporting that. A surgeon may be standing next to you and say, hey, I need your help. We need to do this right now because we need to get to theater, or we need to get this patient to theater, and we have the ability to do that. So I need you to support. And so being able to just walk through those processes and have students and have the training audience understand what takes place was great. I think a lot of their questions were fantastic. I think it was great to be able to really walk through all of those, the process, the procedure, as well as just to be able to manage it and understand, hey, listen, this is not space age stuff. This is quite simple. Being able to manage it and assess it and make sure that you can really reduce infection and reduce bad outcomes. I think it was really a good experience.
And it is probable that the combat medics will be transporting someone with a REBOA from the stabilization point into the role too.
100%.
Yeah, and I think that's one of the biggest things also, that if they never seen it and doesn't know the concept behind it, they will be a little bit more stressed. So now I think we made them understand how REBOA works and the pros and cons and complication that can occur. But now they know what it is and how to manage it. And I think that's one of the best things with teaching advanced skills for non-medical personnel, non-doctors, is that they are wondering, what is this and how are we going to support this? And teaching them that will give them a great benefit to be more confident in transporting patients from A to B.
Absolutely.
Another advanced skill that we gave them was ultrasound. And we taught them how to do fast EFAST, and we've taught them how to do ICP measurement. And I think at the CMC level, with 63 hours of training, they took to it, didn't they? They picked up, and they were able to demonstrate multiple times a fast exam.
Oh yeah, I mean, from my side, it was excellent to see. The technology has gotten to a point where you have mobile phones and you have the ability to walk through a lot of training videos. Then you put it on your, you put it into clinical care. And as you rightly point out, being able to consider ICP, intracranial pressure measurements, being able to do a fast exam, it's absolutely it's brilliant. And I think with the curriculum specifically for this course, I think it was great to see ultrasound visited on just about every single day. So every single day they were really putting their hands on ultrasound. And if not, they were, from a theoretical standpoint, they were describing what they would be looking for and what type of probe they would be using. When we were going through trauma lanes and sort of that prolonged field care, patient care, they were, really applying it with IV interventions, being able to get access as well as being able to do the core components from the curriculum. So it was really great to see that.
Speaking of ultrasound, I had a personal first, which was my first CAT scan. We had a pregnant cat in the classroom, and we got her on her belly, and we were able to see 4 or 5 tiny cats in her belly.
Yes, that's right. In Ukraine, whether you are on the line, actively engaged with the enemy, or whether you are doing training, cats are omnipresent and in Ukraine. And so it was great to we had our own little, a cat running around, and it was interesting to see that. So well done on that. How many did you count, by the way?
I think I count 4, but they were moving around. It was like chasing cats.
Right.
Yeah, and I think you made her give birth a little bit early, because the day after she was gone, and when she came back, she had given birth.
Yeah. So, lads, what are you hoping that this DCRU program will accomplish in Ukraine?
I definitely I want damage control resuscitation in Ukraine to really drive home the benefits of the clinical practical practice guidelines from the DHA's Ministry of Medicine. I really want it to make it accessible, to demystify the CPGs, and I really want the access to blood to be less than hindered, less cumbersome. And there's already a movement really within Ukraine, especially at frontline areas, to get access to blood. Obviously, the rate limiting step is blood. So without the requests for blood, without the adequate access to universal donor and other good blood component therapy, it'll be a challenge. But I would like the CPGs that are in Ukrainian language, as well as the ones that are still being updated and translated, to be accessible, and not only to doctors and paramedics and nurses and EMTs that are already certified in Ukraine, but most importantly to the non-providers, so that they have access to the information, they have access to the clinical knowledge, and they can really start to learn and really start their learning process and their learning journey as it relates to pre-hospital medicine.
Yeah, I think that learning them to use the CPGs and also demystify the thought that some people are thinking that this is only a US centric system. This is only made from the US, but it's actually implemented all over NATO. So I think there's a unified consensus that the CPGs is something that we should use within the NATO forces, and be, because if I'm from Norway coming to help out with the American soldiers, or working with American medics or Ukrainian medics, if we have a common ground of CPGs, it will be much more easier to work together also.
The CPGs are going to increase combat effectiveness, isn't it? It's going to make a better overall military.
Absolutely. And I think access to it's obviously the CPGs, the roadmap, the framework. I think access to better medicine in Ukraine will increase force lethality. And I think having access to really to a better combat medic in Ukraine will increase the lethality of units. And I definitely think that this is something that is oftentimes missed. People talk about medical readiness and resilience, which is excellent and great, but really having that access to best practices as far forward as possible will increase lethality in general. I do also want to comment one other aspect. There will come a time, if we're not there already, where the Ukraine experience will eclipse that of NATO and will eclipse that of the United States. It'll be superior. So the medical experience will actually be superior inside Ukraine, and often in some areas it already is, meaning that what they're doing far forward, what they're doing with less resources, is actually more than what we've been able to accomplish and what we've been able to do as a defense force, as a fighting force And I think it's very important to study that. I think it's very important to learn from that. I think it's very important to be able to describe that. Obviously, as mentioned earlier, it's not a homogeneous stone. So you may have one area, these excellent, amazing, all-star items and tasks and successes taking place. But unfortunately, and sadly, we all know the reality that in other areas, you may actually have significant gaps and shortcomings. And so being able to support those gaps and close those gaps and support those shortcomings and make gains on those shortcomings is really what I think we need to do for our partner force, the largest partner in NATO, that of Ukraine, Forces for Ukraine.
It'll be interesting to see the outcomes now that TechMed North will be running the DCRU in a few weeks, and they're going to be teaching this for the next foreseeable future. How do you think that will change the man on the ground?
I definitely think this is an opportunity. I think it's an opportunity to increase both capacity and really support with capability improvements. I definitely think TechMed North are an excellent partner to be able to support this and drive this forward and be able to really spread the concept, that rooted in the curriculum of the CPGs, but really be able to support with, offering best practices of evidence-based medicine. And I think what the future holds, and we need to get, obviously, I'm very interested in the feedback from not only the instructors of TechMed North, but also the training audience before and after. But I do think it's going to have the opportunity and the possibility of really spreading and really raising the standard and raising the bar at point of injury medicine for Ukraine.
Yeah, and I think that, as you said, John, TechMed Nord is very, very professional and have a great training area, training facilities, and there's a lot of these soldiers coming to TechMed Nord that really will have a great benefit. And I also think that the way we taught it and the way we made them able to do this course after reviewing a curriculum and also changing some of the curriculum while we were down there will give them a good and a great possibility to save lives, because most of the people are focusing on the frontline medics, the guys that is on the point of injury. But we also need to think about how can they keep the patient for a longer period of time, and how can we make more, how shall I put it, give them the more tool in the toolbox to keep the patient alive for a longer period of time. And some of the things that we taught them are really gonna increase that, in my
Absolutely.
opinion.
Lads, my final question for you is this. What advice do you have for the new doctor, new nurse, new paramedic, or the new Ukrainian CMC who is just starting out in their career in austere medicine?
My advice is never give up. Every day is a school day, and we must, in medicine, learn from our failures. We must make success out of those failures, and there will be several failures. But in supporting a patient and supporting a patient care, do not give up, and always show up the next day and make sure you learn from your mistakes.
I think I can just second that, and also that I'm so impressed about the people who came to our courses, the frontline medics and the medics in evacuation and at the stabilization points. There were actually people who was musicians, who was chefs, and they took the task to become medics. And what I saw of those students that we had on the course was that they were really eager to learn. That also referred to all the good questions that we got when we were teaching. Some problems because of translation from English to Ukraine, but since all the CPGs are in Ukraine now, it made it a little bit easier because we could just pick up the CPG. But as you said, John, they should just keep on learning. They get a lot of hands-on experience, and they will learn from their failures, and they will have the CPGs now that they could really go back and have a look at and also follow while they're treating the patient. So they're doing a great job down there.
John Quinn, Eirik Holmstrom, thank you for joining our podcast again. And it was great to deploy with you to Ukraine.
Yeah, it was a great experience for me for the first time in Ukraine, and I would really love to go back there maybe in a couple of months or so and see how TechMed North is doing on the courses. And I really hope that a lot of people out there do the same as we do, because they need more education down there. They need more people focusing on damage control resuscitation Ukraine.
Absolutely. And I can only say thank you so much for the opportunity to support with this curriculum and this course. I definitely look forward to supporting it in the future, as well as spreading the word and getting more descriptive about the course, how it's going, what's going well, and how we need to improve it going forward over the next few months and years. And so thank you very much. Дякую вам за ваш час.
I already forgot most of my Ukrainian, so I will just say thank you.
This has been a presentation from the College of Remote and Offshore Medicine. If you would like to earn CPD credits for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credit, free access to our virtual field guide, and discounts on our e-learning courses. You can join the team on our college website at quorum.edu.mt.